Welcome everybody to our third webinar session today. We are very, very happy to welcome you today to the session which is called Implementing Fetal CMR as a Diagnostic Tool. This is Nadja and I'm Heide. Probably the most of you already know us already. We are both from North Medical and happy to be with you during the next hour.
Okay, yeah, sorry, we're letting people in. We just wanted to say we're very happy you're here. Fetal CMR is really expanding a lot worldwide, and we're happy that you are here today to learn more about it, or just to see what the latest updates are. Okay, this is the topic of today, implementing fetal CMR as a diagnostic tool. You don't have to be sad if you missed any of our former webinars that have taken place, because there is one session every month. There is recordings available. You can access them. We will post in the chat later a link where you can watch them if you're interested. But now it's not the time to be sad, it's time to be happy, because Heide will now introduce the experts of today.
Yes, it's great. Today we have four experts. The first of one is David Lloyd. He's a pediatric and fetal cardiologist from St. Thomas Hospital and King's College London. We are very happy that you are here today, David. The second expert today is Eleanor Schuchardt. She's a pediatric cardiologist at Rady's Children's Hospital in San Diego. I'm also happy that you are here, Eleanor. The third expert is Lorna Browne. She's a pediatric radiologist in Denver at the University of Colorado. And the last but not least expert today is Erik Hedström. He's pediatric radiologist and clinical physiologist at the Skåne University Hospital at the Lund University. So thank you that you are all of you are here today, and we are very happy to talk to you within the next hour. So each of those experts is going to present a few slides, a few minutes, and we very welcome you to discuss or to ask your questions for a later discussion. So therefore, please paste your questions into this chat function. We will collect all your questions and then discuss them afterwards. And very important again, don't be shy, please, because we always learn that each question is very helpful, because this is such an innovative topic and you all learn from each question. So that's very important. And now I'm happy to hand over to David. Please share your screen.
Thank you very much. And thank you for organizing this. I think it's a really, really interesting topic. Hang on, let me just get my slides up. Disappeared. Hopefully you can see them.
Yes,
yes.
we do.
Perfect. So I think a really interesting and timely topic, and I think we've got to a point with the technology where this is a really interesting question. What is it clinically useful for, and how do we actually implement it as something that's beneficial to our patients? So I think I've officially got 6 minutes, so it's going to be a kind of whistle-stop tour. But I thought maybe I'd just do a bit of scene setting, and I think particularly as I'm the first speaker, this is where we are. So we're in London in the UK. This is our hospital on the left. So we're pretty central. We're in quite a cool location. Guy's and St Thomas is the hospital. Evelyn is the Children's Hospital on that site. And King's College London is the university which we work with, and we have university departments on site in the hospital. So just when you hear those words, this is basically all the same place. So I thought, just a sort of quick overview. And I think as Heidi was saying, this is something that's been it's a very novel field, really. And there's been rapid development in methods over the past 5 or 10 years, particularly, although fetal cardiac MRI has been around a little bit longer. And I think we're really in that very rapid development phase. And as a result of that, I think what scanners people use, what methods people use, post-pressing methods in particular, and how they use them are very center dependent. Obviously, many people have the Doppler device, and I think that's enabled imaging for a lot of different people, but there's still questions about how we use it. And I think it is really evolving on a center by center basis. And I think you can really regard fetal cardiac MRI as still an emerging technology. So I think we have quite a lot of clinical experience using fetal CMR, and I really wanted to sort of tell you that story from the beginning, because I think it is really shaped by how things start and how you interact with clinical colleagues. And we've had our own story, and I think every other centre will have their own too. So really our experience started in 2015, where we were really being speculative about what we could possibly do for fetal cardiac imaging with women in the scanner, really as part of other research projects that we were really piggybacking onto things. 2016, we started using some motion corrected slice volume registration to give us 3D volumes of the fetal chest, and that worked very well. And that was the real synergy that started our ultimately led to our clinical service, that particular method. We validated that, and we've had a clinical service in place since 2019, 2020, which is now reimbursed by the hospital. So it's a real clinical service for our patients. They get referred, the scans are paid for as part of their care in the NHS, which I think other health systems have different sorts of challenges, but all of our patient care is free at the point of care for those patients, and that's reimbursed by the hospital as part of their clinical care. And now we've started using the Doppler ultrasound device in 2022, and I think that's actually helped us a little bit, and it's essentially quite an exciting addition. And maybe speak a little bit about what could be happening in the future, fetal CMR for us. So I'll just breeze over these. This was like the initial work, and all this really showed was we had an open referral with our fetal cardiology colleagues and said, just send us anything where you think we could give you more information that would be helpful. And really, from a very early stage, what people were saying is anything that was vascular, a vascular component of a congenital heart disease diagnosis was the bit that they would really like some better quality imaging, or perhaps more detailed imaging than two-dimensional echo. That was very difficult to achieve with single slices, but what we started to do then was apply this motion corrected slice volume registration developed for the fetal brain using overlapping 2D slices. We used single shot fast echo slices, which gave us a kind of black blood contrast, applied that, and that worked really well. So we were able to generate pretty reliably, even from motion corrupted stacks, these kind of 3D volumes, black blood volumes, which we could then go on and segment. And essentially, it was a good application of the technology, but it was also really complementary for us because it was exactly what the fetal cardiologists that we were working with were asking for. So that's where I was saying that synergy. We had a really nice synergy from the beginning with our clinical colleagues asking for something, and then we were able to provide it pretty quickly. And that's been the seed of our clinical service. This is where this has all grown from. So we did some validation work. We published that back in 2019. Lots of validation work with echocardiography, measurements, visualization, and so forth. About 85 patients in that series. And then we approached our trust, our hospital here, and said, we think we can offer this as a clinical service. We're still getting referrals. And this has been our clinical referral template since then. So really, it's all vascular, pulmonary venous, arterial anatomy, coarctation of the aorta is a very specific condition, vascular rings. And then we did include congenital heart disease, particularly with lung involvement, so hyperplast, TAPVD, recognizing that particularly imaging the lungs is quite a useful adjunct with MRI. As I said, we now reimbursed, and we are the only centre in the UK, or I think there's certainly other centres who are starting MRI, but we have quite an established clinical service here, and we do receive referrals now nationally for fetal cardiac MRI scans. We are on patient 616, I think, as of this month, clinical patients. And that's probably over a 5 or 6 year period, and we work very closely with a team here, the team that we originally piggybacked on at the beginning, actually, and we consistently get extra cardiac findings, brain and body, reported in all of our clinical patients, and that in itself I think can be quite an interesting thing to think about when we're thinking about clinical utility, some of the extra cardiac findings that can be picked up by MRI. This was an audit we did a few years ago, but I don't think the spread has changed that much. This is kind of what we end up seeing here. They're all vascular diagnoses, essentially, mainly coarctation, that's a big group, but vascular rings, and then other specific diagnosis, particularly pulmonary blood supply. And then just some examples. So this is pulmonary atresia VST map curves on the right with the postnatal CT, on the left with motion correction. So just to really show the kind of complexity of anatomy and how you can imagine this can be very difficult with ultrasound, and you are essentially having to wait until you can get postnatal imaging, and you can kind of bring that into the prenatal realm with some of these methods. And this is just a quick example, tetralogy of a fellow with absent pulmonary valve, so grossly dilated branch pulmonary arteries. So, you know, there are some potential anatomical benefits from these cases. Sorry, there's someone drilling outside this room. What you can also look at as lung, and what we're seeing here is fluid trapping in the right middle lobe, for example, and that corresponded to air trapping from bronchial compression postnatally. So I think you'll see some other examples of how lung imaging can be complementary, but just a potential clinical event. So we were able to sort of, if you like, if not predict, then certainly say this fetus was at extremely high risk of airway compression postnatally, which is associated with this condition, and that ended up being the case. Coarctation, so 3D anatomy is useful, and I think, but probably not the whole story, particularly for the really subtle or grey cases. And this is some work we published actually combining the 3D MRI with some of the phase contrast flows, which we use metric optimized gating as developed by the team in Toronto. And this is just a chart from that publication, and now we apply this clinically. So we use this on our coarctation patients. We measure ascending aortic flow and what we called isthmal displacement, which is roughly equivalent to the posterior shelf. And it gives us a percentage risk of coarctation of the aorta. So we can combine those two, and we now report all of our coarctation of the aorta scans with a percentage risk. And this is based on reviewing a previous cohort, reviewing a variety of parameters and coming up with this model. And like I said, we do actually apply that clinically. So I think it's worth mentioning that. Doing a lot of work in this area, and I'm sure we will improve with how we model this. And then final bits. This is actually motion corrected volume with some image-based gating. So we could potentially be looking at intracardiac anatomy, functional data here, and this is a big work stream of ours. From the same data, you can actually derive velocity and direction from the in each voxel from sort of slightly different than 4D flow. It's from the overlapping data and the fact that these are balanced sequences. So these are kind of really interesting techniques, and I think what we're really interested in doing now is seeing how the Doppler device can actually help us with a lot of this and how it compares to some of the image-based gating methods. This is just some of our recent forays into imaging with the device. So this is just off the scanner gated phase contrast sequence here. This is a 3-vessel view, fetal 3-vessel view. This is obviously a 4-chamber view. So this is a big active area for us, looking at how we can really improve some of our gating pipelines. So I think, yeah, I think the future for cardiac MRI in terms of the technical progress, I think you know, what you compared to what you see postnatally, I think we've made a lot of progress in that direction. And I suppose the sort of thoughts to leave you on before the other speakers to say we're quite established here. We have a robust set of referrals, but that's very much centered around the technology that we've developed here. I think the set of referrals is likely to increase with the technology, but does one size fit all? So I think, you know, this is our experience, and I think it's like I said at the very beginning, it's a very interesting discussion to see how others view this tool and how it can benefit their clinical services. That's our team, and I think that's the end of my talk. And I'm sure it was more than 6 minutes, so I'm sorry about that.
Thanks, David. Was directly one question I would like to raise directly. So the first reference, the neuromotion correction one, could you maybe paste that one into the chat function? There was someone asking. That's great, thank you. All right, and then we directly hand over to Eleanor.
All right, I hope you can all hear me. I'll go ahead and get my slides up. Okay. All right, so I hope that you can see my slides. Stop me if you can't.
Wait a second, Eleanor.
Okay.
It's only black right now, but now it's coming. Yes, now I can see it. Perfect.
Okay, it might just be on a little bit of a delay. Okay, my team says that it's refreshing. Okay, so I'm a fetal fetal cardiologist and postnatal CMR physician. And our program at Rady Children's Hospital is a lot less developed than Dr. Lloyd's. But our indications are very similar. So, and they're continuously evolving. We primarily target patients with uncertain vascular anatomy, either systemic or pulmonary blood flow concerns after birth with ductal dependency, heterotaxy. We are starting to scan for dual indications of CNS abnormalities and congenital heart disease, and when CHD is highly suspected, but the fetal echo is limited by maternal obesity, stuck position, or advanced gestational age. I'm hoping my slides will go forward here. Yep. So one of the challenges that I've encountered as I've started to develop a program in the United States is that we just have a single CPT code for billing of fetal MRI. This encompasses all of fetal MRI, so brain, body, heart, chest wall, all of it. Here are the RVU values from that billing code. And in my institution, our radiologists are a separate entity from our cardiologists. And so we needed to kind of negotiate that agreement to share the revenues and RVUs from each case. And I think that there's a role here for advocacy as fetal CMR continues to grow, that we need the creation of additional codes and a cardiac specific code. Like many programs, the referral pattern, our patients begin their journey in OBGYN or perinatology, where they have an abnormal scan. They then progress to fetal cardiology, and then some are referred for fetal cardiac MRI, as I discussed. That scan produces a result. But this referral pattern also has other players that we certainly can't ignore. We frequently refer for prenatal consultation for neonatology, general surgery, CT surgery, and genetics in the fetal period. And we have to be certain that the results of our scan are communicated back to all team members in a thoughtful, timely fashion. And of course, as programs establish and grow, knowing that the landscape of your practice area is vital. Utilizing a care conference is helpful. And, of course, get the recommendations to those taking care of the baby. We are scanning 34 weeks and above. We scan on a Siemens 1.5T SOLA platform. These are just a few notes about how we do it. We highly encourage the support person to be in the room. We have music on for the mothers and encourage them to kind of zone out. We have certainly found that a calmer mother equals a calmer baby with less fetal motion. So now I'll go into some sample cases. So this was a 35-week fetus who was referred for a suspected vascular ring. The fetus, we based on the fetal echo images, we weren't entirely certain if this could be a double arch or a right arch left duct. And the mother really wanted to deliver at her local regional hospital, which did not have a high level NICU. So this is the still, just to orient you all, this is an axial stack with our cranial slice on your upper right and the most caudal slice on the upper left. And I'll go to my next slide, which will have the cines. Starting here on the upper left, you can see the level of the vascular ring. This is a left duct, right arch with airway and esophagus in between. And we were able to see both subclavian arteries as well on the most cranial slice. Let me just pause this and go to the next. Pair slice 4, we were able to see a 3-vessel trachea view, though somewhat limited. There is some degradation of the images when I import them into PowerPoint. And this that 3-vessel trachea view also showed the carina. Going on to the next case. This was a 34-week fetus with tetralogy of Fouleau and was suspected of having an absent ductus arteriosus. So we wanted to evaluate if the duct was present. There was concern that this baby could be pretty very cyanotic after birth. Here was our 4-chamber view. Our short axis stack. And a basilar short axis stack. Let me try to get this onto play and pause this one. My other one isn't pausing, but hopefully it's not too distracting to you. In this kind of more basilar short axis stack, you can see the hypoplastic pulmonary valve leftward of the aortic valve. On this scan, we did not see a PDA. We did not recommend prostaglandin, and the diagnosis was confirmed after the baby transferred to the cardiac unit. And he ended up undergoing an early tetralogy repair. So my next sample case is a 36-week fetus with heterotaxy. This was a very complicated fetal echo and with multiple challenges. It was double outlet right ventricle with pulmonary atresia, complex pulmonary arterial blood supply, and suspected of having mixed obstructed TAPVR. This is a sample image from our fetal echocardiogram. This is left. You'll note the morphologic right ventricle is on the left side. This is L-looped. This is the descending aorta over here, and a dilated left-sided hemiazygos. You can also appreciate some separation between the pulmonary veins and the common atria, indicating TAPVR. Here is, so this scan was pretty challenging for us, and I apologize that the stack is playing a little bit quickly, but this is an axial stack. Our fetal CMR early in, here, let me try to, this was the hemiazygos arch, which was on the left side, which was quite large. We could see some dephasing artifact adjacent to the descending aorta. Our objective with this scan was to try to help delineate the complex arterial pulmonary supply, the MAPCAs, and we weren't entirely successful in that objective. However, we felt that our images were still somewhat helpful in care of the baby. And this is a sagittal view. We could appreciate that the MAPCAs were rising pretty high from the descending aorta. And just to show this baby's postnatal imaging, this is a reconstruction of the pulmonary and systemic veins. You can appreciate that this was a kind of vertically oriented confluence. There was dual drainage into the bilateral SVCs, with the left hemiazygos being the dominant drainage from the lower body. The pulmonary arterial supply was also quite complicated. And this is the postnatal CT showing the MAPCAs from the descending aorta. So I think without a robust pipeline for motion correction, we relied heavily on our cine images and didn't quite have the 2D resolution to reach the goals for this fetus. But as I mentioned, it was a pretty high reach for us. Let me go on to the next. And the last fetus I'll share was again a tetralogy of Fallot with an absent ductus arteriosus. This patient also was undergoing a brain MRI or an examination for suspected CNS abnormality. Here was our 4-chamber view. The VSD in this patient had some inlet extension and the AV valves arose at the same level. Our branch pulmonary arteries were confluent. You can see the white dephasing artifact of that left pulmonary artery, and the right pulmonary artery had more of a black dephasing artifact in that image, and a left-sided aortic arch. And so those are the cases that I had prepared to show. I think that, you know, we are early in our journey of fetal cardiac MRI, but we're eager to continue. Try to stop share.
Thank you so much, Eleanor, for this insight into your experiences. I think this is very, very valuable for many of our listeners here, or participants. And we now directly hand over to Lorna. Please share your screen, Lorna. Oh, it's already shared. I can see it already. Thank you.
I did forget to turn off my mic though, so I have to go back again. Okay, here we go. Almost ready. So hopefully. Okay, great. Hopefully you can hear me and you can you see
Lorna,
me.
it's 1 second. It's not in your presentation mode so far. Maybe you want to change that.
You don't see the slideshow yet?
I can see your slide, but I can also see the.
Yeah, let me get let me go back in and then
slides.
reshare again.
Yes.
So
Okay.
stop sharing and then reshare. Thank you. And then reshare. And now hopefully you can see slideshow.
I can see your slides, but it's the slide view and not the presentation view that I see. But it's up to you. It's fine.
Yeah.
Like maybe you just share another screen.
Yeah, that's probably what I'm going to have to do. 1 second.
No worries.
Let's try this. This is what we tried at the beginning, so hopefully this will work.
Yes.
Yeah.
No, it's perfect.
Okay, great. So my name's Lorna Browne. I am from Children's Hospital Colorado, and I'm going to share our experience. We've been doing research cardiac MRIs for about 2.5 years, and then clinical cardiac MRIs, fetal cardiac MRIs for probably nearly a year. We started really going for it last April, and there's been a massive increase in the number of clinical cardiac MRIs, fetal cardiac MRIs we're doing really since that time. We're in the 50s at the moment. Okay, our indications are very similar to David and Eleanor's. Heterotaxy, hypoplastic left heart syndrome with a concern for atrial restriction and pulmonary lymphangiectasia. Congenital heart disease, where there is also an abnormal MFM ultrasound. I've just given a very common example there of microcephaly. Congenital heart disease with a concern for an underlying syndrome, and congenital diaphragmatic hernias, where we're also trying to get ventricular and pulmonary artery sizes. And just like David and Eleanor, this is in the context of an entire fetal MRI. So we look at the brain and body in all patients for our clinical scans. So we do our clinical scans generally around 32 weeks. Most of our referrals are coming from the fetal cardiologist. So when they have a very challenging echo that they have difficulty resolving, we do our best to try and help when patients are coming from fetal MRI. We do correlate all our images with the fetal echo and talk extensively with the fetal cardiologist about what we see in MRI, correlating both the echo and the MRI together. And we have a consensus reading for our fetal cardiac MRIs. We're very much still in the learning phase, and so at least a couple of us look at these cardiac MRIs, and myself and one of my cardiology colleagues to try and get as much information as possible from them. Importantly, we also do a multidisciplinary family meeting. So we are showing these images to the patients. And I do think they, in general, really appreciate this. Just going to show you a couple of cases. These are all just recent cases, the last couple of weeks. This was the first case that we've had that was really specifically to help with postnatal surgical planning. So this is a 32-week-old fetus with suspected heterotaxy. The baby actually did not turn out to have heterotaxy, but we were asked really to sort of try to evaluate the position of the pulmonary veins and systemic veins with respect to surgical repair postnatally. So this baby had azygous continuation of the IVC, so there's the azygous vein there. This is the hepatic veins forming the suprahepatic IVC, and you can see the large azygous vein going into the right-sided SVC. This is the trachea here in the center, and then the left side of the aorta. And we were able to show the pulmonary veins. They were actually coming in to both atria on either side of the atrial septum. The baby had L-looped ventricles, and the aorta and MPA were both coming off the right ventricle. So it's double outlet right ventricle with ventricular inversion, and the aorta was anterior. And you can see also the aorta is quite a ways away from the LV for potential postnatal baffling. See if this will play. Good. So these are the cine images from this exam, just showing, going through that again, just showing the azygous continuation of the IVC, the ventricular inversion, the pulmonary veins coming in on either side of the atrial septum, and the aorta and the pulmonary artery coming from the right ventricle, with the root of the aorta really quite a ways away from the left ventricle. This is the black blood that we did. This is again a multiplanar black blood, and then we can reformat to do an MPR, which we can post-process in any plane that we want. And this is really helpful for the extracardiac anatomy. You can see the azygous continuation of the IVC there. But because the PDA, we knew there was a PDA present because of the spectral pattern on Doppler, but it was really, really, really hard to see on echo, and it actually was very hard to see on our regular planes. But when we multiplanar reformatted this, we could see that the PDA is actually coming from the innominate artery and going into the left pulmonary artery. Oops. Let's see. Sorry about that. Click the wrong button. So, so how did the cardiac MRI help in this case? Well, it delineated the pulmonary valve, the pulmonary vein positioning, and also the position of the aorta with respect to the LV, which actually we weren't asked about, but I think a surgeon actually found that the most helpful. And this definitely affected the patient counselling. They were certainly counselled, favoured a single ventricle palliation. Obviously, this is guarded because we want to look at this baby postnatally, but the parents have sort of steeling themselves for a single ventricle palliation postnatally. And parents definitely had a greater understanding of the baby's anatomy after we were able to show them all these images. And I think potentially this could help the postnatal echo as well, because this is obviously a very challenging case. And I think the echocardiographer, knowing where the pulmonary veins and PDA are based on the fetal MRI, I think will maybe shorten and help the postnatal MRI, postnatal echo, sorry, rather. This is again one of our common indications. This is a baby with HLHS with restrictive atrial septum. This is obviously severely restricted atrial septum. This still image just showing you hugely dilated pulmonary veins, and this is the atrial septum going into the right atrium here, massively dilated left atrium, and everything is just incredibly turbulent on the left side because it's so restrictive. And you just have this horrific turbulence. This is the cine images from that. I've certainly never seen such a degree of atrial septum restriction before, and you can see the degree of pulmonary lymphangiectasia is really, really marked, and even on the these cine images, you can see there's pleural effusion and really marked septal edema there, and this is the T2 haste of the same patient. So certainly no difficulty in making the diagnosis of atrial restriction in this case, but you know, I think the majority of our cases, I do find, go back one more. So hopefully that won't happen again. Teams can be somewhat unforgiving. Okay, the majority of our cases look a little bit like this, where we see, hopefully this will play. Oh. I'm not sure this is going to play, and I don't want to risk it blinking again, but a lot of times we see a lot of the atrial septum, and I find it very hard to tell whether if the atrial septum is restrictive or not in the majority of cases. I'm still definitely feeling I'm learning and getting a sense of what's normal and what's normal for the atrial septum in patients with HLHS in these borderline cases. I find it very challenging. I do find the pulmonary veins, looking for pulmonary vein dilation, to be helpful, but just to emphasize, there's still a lot to learn in these cases about where the boundaries of normal and abnormal are, and sometimes it can be very grey still, but generally we are still helpful in these cases. We can say there's no pulmonary lymphangiectasia, and we generally get a good look at the aortic arch. In this case, the echo thought the arch was severely hypoplastic, and the fetal MRI showed it was only mildly hypoplastic. So our emerging indications are changing all the time, and David talked a bit about this. Tetralogy of Fallot with absent pulmonary valve is really the next disease I think we're going to see a lot of patients coming for, and this it's something we have seen in the past. This is before our fetal cardiac MRI program. So this is a baby with very severe absent pulmonary valve. This is the postnatal CT done at 1 day of life, and the baby has the right side of the aortic arch, but really, really dilated pulmonary arteries. The bronchi were severely compressed. This is hyperexpansion of the left upper lobe. There's a lot of airspace pacification in the right lower lobe, which is really probably fluid trapping at this point. And the corresponding fetal MRI, you can see those areas of T2 hyperintensity in the left and right lower lobe there that correspond to those areas of fluid trapping postnatally. You can also see it in the left upper lobe that was air trapped postnatally, and we could see massive pulmonary arteries. And you can also see, I haven't shown them on this, but severe bronchial obstruction, because obviously we see the bronchi incredibly well in the fetal period because it's filled with fluid. So, I think there's an awful lot to offer in this disease with fetal cardiac MRI, and it does seem to help prognostically if you're able to see, what's going on prenatally. It does seem to correlate with prognostic, what happens afterwards. So, just got a message there to say can't see the slides. Sugar.
Yeah, but we can see it, Lorna. No worries.
You can see?
Yeah.
Okay.
If someone cannot see the slide, you might go out of the meeting and try to go in again. This might help. So we could see them, Lorna.
Oh, good. Okay. Sorry, well, I hope that was useful for you. That's just really where we are in Children's Colorado at the moment. And now I'll pass on over to Erik.
Great. Thank you, Lorna, for this very clear insight in your clinical cases. And Erik, now it's your turn.
Thank you very much. And let me see if I can share my screen. Can you see my slide?
Yes, we can see them well.
Great. So thank you very much for inviting me. As an overview, going back, we started out with a clinical service, autumn 2017, with reimbursement since. And we still see CMR, and probably will for the future to come, as a second or third line examination, where the patient has always done at least one dedicated fetal echo before coming to us. We mainly see the referrals from pediatric cardiologists, seldomly from the obstetricians. So we have a different setup compared to King's, where David started out talking about their vascular perspective, whereas we have more of a cardiac perspective. So our referrals are on complex cardiovascular malformations, where there is insufficient information from ultrasound, usually questions about intracardiac anatomy and function, and commonly, but less importantly, the vascular anatomy. We generally run the scans in late gestation and also have quite a few cases with maternal obesity, in relation to the relatively slim pregnant women in Sweden. And then we also have the very specific question about restrictive intact atrial septum and pulmonary lymphangiectasia particularly. So we are running this as a 1.5 Tesla scanner, and we've been using the SmartSync since 2016, 2017. We're doing this with a combination with a spine and 18-channel coils, and nowadays we run this mainly non-breath hold sequences. We are sticking with a normal operating mode with a specific absorption rate less than 2 watts per kilogram. And we also look at the gradient levels. We use flip angles based on these SAR limits. And this, together with the no sedation and no contrast agents, is very likely to be discussed further. Also at the coming ISMRM in early June in Toronto, considering the general safety restrictions and guidances we do have for fetal and dedicated cardiac fetal CMR. Just to show, this looks very pixelated on my show screen, not on my computer main screen, but this is an image from Dr. Reed's publication 2021, where we in this case have a maternal obesity case and don't see very much at all, whereas with the cine images to the right have a very clear view of a large atrium and a common ventricle. I just wanted to go back to this slide, which is in the colors between 2011 and 2020, color-coded for the univentricular heart detection rate in Sweden, the AVSDs, overriding great vessels, including Fallot and their variants, and also TGA and aortic coarctation, where I believe univentricular hearts is not very much of a question comes to echo, whereas we can make probably more of a difference for the other parts, even though they are increasing rapidly over the years. I also just wanted to show this image quickly. We should remember to also use our static images. And can you see my pointer in the screen?
No.
No. Okay, so the top left image, I have the AO for the aorta. Top right image, we see the branches from the aortic arch. Bottom left image, we have the right and left ventricle. And then on the bottom right side, we have the left ventricle and the right ventricle marked, and also the outflow tract, in this case, of the transportation of the great arteries. I have here chosen 3 cine slices. So this is a transversal stuck throughout the thorax of this baby. And to the top left then, we see the ventricle on the patient's left side. So the patient's left side is to the right in the image. So the stomach we see on the patient's left side, and just in front of that, we see a small white dot pulsating. And if we go to the middle image, we see a common large atrium and a larger left than right ventricle in this case, but particularly we don't clearly see any of the pulmonary veins here. So going back to that image to the left, the pulsating white dot in front of the stomach is actually a quite extensive vertical vein, in this case of total anomalous pulmonary vein drainage, going down to the portal vein system quite far down into the abdomen. So this is then a case of a common AV valve where we also see then a large apical ventricular septal defect, and we have a double outlet from this left ventricle as shown to the right, where we also see that the pulmonary artery comes from the left ventricle and also the aorta from the left ventricle, medial from the pulmonary artery. So this is a double outlet left ventricle with TAPVD and TGA. Overall, outside of the heart though, we have normal lungs, no lymphangiectasia. We did not see any spleen, so we also had other signs of heterotaxy. And all that information was then available before birth to prepare the parents to be. This is a case where the echo shows an intact atrial septum. We have dilated pulmonary veins, We see flow reversal with atrial contraction, and there was also no vasoreactivity during maternal hyperoxygenation. So this can be considered high-risk patients with then signs of pulmonary disease. And then we wanted the MR scan done, particularly for pleural and pericardial fluid, and the nutmeg pattern for lymphangiectasia. So even though we had all this information, it was planned for a vaginal delivery and a clinical assessment immediately thereafter, and then palliative care in this very challenging case. But again, the parents were more prepared than they otherwise had been, as also been discussed by others today. Also coming back to a comment about who looks at what in these babies. So to the left here, and now you cannot see my pointer, but in the thoracic part of the vertebral column, you see triangular shaped dark vertebra instead of the flat square shaped vertebra. So we have vertebral malformations. We also had renal malformations, and in the image to the right, we can also see abdominal intestinal malformations. So in our center, we have the pediatric radiologist looking at the entire fetus except for the brain. But it is the pediatric radiologist screening for brain abnormalities, and then the neuroradiologist is asked if there are any particulars to discuss. And as we've heard already, this seems to be quite different in different centers. And I just wanted to show as a final slide also what I believe will be important for the future to come. So this is a 3D cine acquisition where we to the left see the short axis with a smaller left ventricle and a larger right ventricle. And we to the right see a 4-chamber view with a bit of pericardial fluid, but otherwise low contrast. 2 different methods have been used for reconstructing these images, where the left-hand image is a more modern one. And as presented by Peak in MRM 2022, I think the importance here of true cine acquisitions will be that we will acquire a box over the heart instead of planning and imaging a moving target as the baby is. There are, of course, other solutions to this too. And this can be self-gating, but of course it can also be using the SmartSync device to input the triggering signals to simplify the reconstructions. And with that, I thank you. I'm not sure what you can see. I don't see.
Erik, we only see a black screen right now. I think you need to share your screen again once more.
I don't have anything to share. I stopped the presentation.
Okay, so you are done.
Yes, I see David right now.
All right. Thank you very much, Erik. Thanks so much for your presentation. So let's move on to the discussion. And we first want to start with a question that was raised and also discussed a little bit in the chat regarding the CPT code. And Eleanor was already answering a little bit to that. However, we would like to ask also Lorna, as she's also in the US, if you, Lorna, you can also comment on that. The question was if the same CPT code 74712 can be used even if the only scanned organ is the fetal heart. Do you have any experience with that?
I don't believe you can only do it for the fetal heart. I think you have to, there are some reporting requirements that you have to meet. I'm not exactly sure what they are, but I think you have to make some reference to the body and the brain with that CPT code.
Okay. David and Erik, do you also want to comment on that, or it's probably completely different?
Yeah, not relevant. Not relevant
yeah, all right.
to us.
I agree. Okay.
Like I said, I think we have the advantage of a different healthcare system here, and I think we're not nationally commissioned. We're actually the way that it works, we're reimbursed by the trust, but I don't think we have the same complexities around how we cost for our scans for sure as you do in the US.
All right,
Quite
and let's
similar
jump.
for us, and quite similar to us, as David says. I mean, even though we have codes for a fetal MRI and a dedicated code for fetal CMR, if there is anything to be reported on the brain in the fetal CMR, there is just that one code and no extras.
Yeah. Then let's jump to a question that was raised by Diana Bardo. Are each of you using fetal CMR independently or always as an add-on to clinical fetal body or neuro investigations? Who would like to answer first?
I mean, I can say, so currently we are doing fetal cardiac MRI as a primary investigations. That is the referral indication. And I guess, you know, we would be doing brain and body reporting as an adjunct. Obviously, if there's a pre-existing brain or body extracardiac finding, we will, we'll focus on that. But we do report brain and body secondary to the fetal cardiac MRI as that sort of primary indication for us.
Similar for us, as I said, we have our fetal CMR on one scanner actually, and the fetal MRI on a different scanner, completely different setup. But report on what's needed and look through everything we acquire, of course.
Yep. Similarly, we do everything. We will tailor our exam to the primary indication, and it's probably about, I would say, 75% the primary indication is cardiac, maybe slightly less, maybe 60% the primary indication is a cardiac. And in those cases, we'll start off with the cardiac sequences. Most of the body stuff I can see in my cardiac sequences, so that does mean that I can really, certain cases get two birds with one stone, getting the body anatomy as well in my cardiac sequences, and then a shortened brain at the end. But everybody has everything, and then we just tailor it as to what the major abnormality is in how much time we spend on that.
Similarly, we try to prioritize the primary indication of the scan, and I'm physically at the scanner during our scans, and then correspond with our radiologist by phone as to whether or not the non-cardiac objectives are completed.
David, you raised your hand.
Yeah, I was just going to make, because I thought it was really interesting. I can't remember if it was Eleanor or Lorna said that in one of their referral indications was extracardiac abnormalities in the fetus as like a referral indication for cardiac MRI. And I think that's quite interesting to me, because I think what we've realized over time is here that, when you look more broadly from a sort of fetal medicine perspective, often we do have patients who have congenital heart disease, but perhaps have not opted for genetic testing in the pregnancy. There may be other things suspected, and we can, particularly for those types of conditions where you might have a strong association with extracardiac abnormalities, I think MRI is a little bit more sensitive in the terms of the brain or body imaging and picking up some subtle features which may be soft markers for genetic conditions, maybe actually avert pathology. And I think we're getting the sense over time with our clinical colleagues that we are getting more referrals that, if you like, are a little bit softer from the cardiac point of view, but there's these other lingering things in the background, and they're actually really keen to see if the MRI can pick up some extra cardiac things which will help them look at sort of overall genetic risks or syndromic risks in the fetuses. So I was quite interested that you put that as a primary indication, but I think there's definitely something real there because we're seeing it in our clinical colleagues.
Yeah, it was that second case of tetralogy of Fallot with absent ductus arteriosus. And I believe, if I recall correctly, that fetus had an absent cavum septum pellucidum by fetal ultrasound. And so they wanted to re-examine the brain for that reason. Yeah. That patient also had an expanded NIPT, which was negative, but did unfortunately have gastrointestinal diagnoses that we did not detect in the fetal period.
Yeah, we've had very, very similar experiences. Just things being picked up, which really changed the ball game a bit for her in terms of counselling. It's very separate to the congenital heart disease, and I think MRI clearly is just a bit more sensitive in some situations for that.
Yeah, I think overall we're just always learning.
Very true. We want to raise one last question. Lorna, in one of the cases that you presented, you said that the surgeons actually requested the fetal CMR to be performed. How did you get to the point that they actually are aware, you offer the service of fetal CMR, and what kind of benefits do they see and take to consider it in their pre-surgical planning?
Well, how did they know? I think that myself and my colleagues were pretty good about doing some advertising internally. So, whenever we postnatally see a CT or a cardiac MRI, and we know we did a fetal cardiac in that case, when we're presenting it, to the surgeons, we go, and look what we do, prenatally we did this. And certainly we try to show them, the really cool cases that we've done, try to maybe email them. So there's definitely a little bit of self-promotion going on there in order to advertise. I think we're a long way away from that being, a usual thing for our surgeons, and we're going to have variability amongst our surgeons, where the older surgeons really don't see any value in it, and then the younger surgeons coming through who are used to it or who are becoming used to it, and who maybe are more comfortable with looking at these images, because I think that's also a restriction with maybe some people who are not comfortable looking at fetal MRI. They don't find an advantage in it. But if you started looking at fetals early in your career and you become very comfortable with it, then you're more likely to find benefit. And they're the people who are going to start asking for it. We've seen this time and time again. We've seen this with fetal MRI. As fetal MRI came in over the last 20 years, and we've seen it with cardiac MRI and cardiac CT. If you can offer something that can see something better, and it can help in a diagnosis, then inevitably it comes into the mainstream.
Thank you.
All right.
Can I just make a little comment? Just one quick comment. I'm aware of the time, so it's not necessarily but I think it's interesting because I'm seeing what the other presenters have said, because I think something that's come up in previous discussions that perhaps we haven't mentioned. But I know that there are groups who are more interested in this application, is actually using MRI as almost more like a screening tool. So, for example, where ultrasound has been very difficult, or this patients present late, or they have high BMI, for example, which I think actually all four speakers very much saw this as a sort of secondary level investigation after they'd been seen by an expert in majority of cases, if I read that correctly. So, not necessarily asking a question, but I suppose if you're talking about clinical applications, I think that's part of the debate is, what is there actually a screening kind of role where, you don't have any diagnosis and you're putting them in an MRI scanner to see the heart, at all. And yeah, I think that's another very interesting sort of discussion point. And can MRI do as well? If ultrasound has failed, I'm not sure. So, but just worth mentioning.
Okay, one last very quick comment from you, Lorna, and then we need to finish this webinar.
Yeah, I just wanted to answer David. Yeah, definitely in anhydramnios, we've had a couple of patients referred for anhydramnios because bladder outlet obstruction has a high correlation with congenital anomalies, and so we've done that where they really can't see anything on ultrasound or fetal echo because of the anhydramnios, and we've just got some basic functional sequences. So I do think there's a role for it in that particular indication because there's a strong association.
Yeah, interesting.
All right. Thank you for this very valuable comments. And now we are already coming to the end. Let's just make one more note that this webinar has been recorded actually, and we will send around the link tomorrow latest, and then you can also forward it to all people that might be interested. And one last slide, would like to share with you that there's going to be the next webinar session in May, 3rd of May. And as this was quite clinical today, the implementation into the clinics, the next webinar will be a little bit more technical again. So this will be a step-by-step to the 4D flow images, and there we concentrate on flow. Yeah. That's it for today. Thank you very much for being with us. And
hope to see you in the next one.
Hope to see you.
Thank you.
Bye-bye. And thank you for your participation, Erik, Lorna, David, and Eleanor.
Bye-bye.
Bye-bye.
Thank you.